So in terms of intervention, there's a lot of different approaches that we could take, and I think this is just how we approach this has evolved quite a bit over the last 10 years or so. But I think generally speaking, we want to treat sort of the underlying disorder. If you think back to those contributing factors, things like depression, psychiatric illness, chronic pain that can contribute to someone's suicide risk, and in addition to sort of those specific suicide indicators, it's really important to be treating and managing those. So our case, again, one of the things that took her low acute risk down is because her depression was being treated. It was stable. So treating those underlying factors is really important, but it's not, we can't solely focus on that. There's a lot of evidence showing that we actually need to be treating suicide specifically, and a lot of our evidence-based treatments that we have for suicide actually target suicide and suicide-related behaviors, cognition specifically. So really some combination of both of those is really kind of the ideal. In terms of actual evidence-based treatments or practices, most of them really focus on preventing reattempts. So they're really targeting really high-risk populations or indicated populations who have already engaged in some form of suicidal behavior, and the really goal is to prevent reattempts. We really don't have a lot of, we don't really have evidence-based interventions that really, true prevention interventions that prevent the onset of behavior. I think that's an area. Problem-solving therapy has, or problem-solving skills in general have been long recognized as a protective factor, and there's some actually really interesting studies done with school-age children. The Good Behavior Game, I don't know if anyone's heard of that, but basically it's promoting problem solving and pro-social behavior, and they actually found that that does prevent suicidal behavior just in the long term. That children that got that intervention in grade school actually had a lower risk of suicidal behavior than those who did not. So really a great line of research that they've done. But problem solving and cognitive behavioral therapy for suicide, or cognitive therapy for suicide, as well as dialectical behavior therapy are the three evidence-based interventions that we have for preventing, again, reattempts or suicidal behavior. These things I know are being implemented just in varying degrees in the VA, and I mean, in terms of DBT, this is I'm talking to everyone here who, this is, Washington, so I really don't need to say much about it here, but and I'm not obviously going to go into a whole lot of detail about these interventions, other to basically say that these are sort of what we know as the evidence base. There are other ways and other types of interventions that sort of really target aspects of suicide risk that are really integral and that we're finding really matter. So things like treatment engagement. Again, if you think about that really high risk period after hospitalization, the thing that really seems to differentiate those who do die by suicide and those don't is treatment engagement. And it's a very, very difficult time to engage patients in treatment as well. So there's a lot of challenges, and I think some of the strategies and interventions for how we're doing that have changed and evolved, and we're getting more creative with it. So how can we, do things like send caring letters and sort of more frequent but short contact with patients to keep them engaged and to sort of keep them connected. Home-based care is a really big area that's we're looking at really with relation to suicide risk too. And I know Lisa alluded to this before, but a program that we have that started as a pilot and is sort of really growing into a larger clinical demonstration research project, multi-site, is basically looking at meeting with patients while they're on the unit, sort of setting a safety plan with them, following up with them via telephone within a day or two after their discharge, and then doing a home visit. Again, reevaluating where they're at, looking over their safety plan, and seeing if that increases treatment engagement. The preliminary data look really good, and we're hoping to look at that even more and look at sort of how we can model this and across the VA and implementation and feasibility in general. So. Again, I kind of touched on this, but most of the data out there as far as interventions that target suicide have found the greatest reduction in the first 3 months. Again, these are specifically targeting suicidal behavior or different aspects related to suicide. Treatment engagement, huge. It's really hard to have an effect or impact if you can't get people to come to treatment or engage in treatment. These interventions are only effective in the sense that people are coming and they're actually getting exposure to it. I think DBT does a really, really nice job of addressing that, and some of these other interventions do as well. Does anybody here have training in DBT, cognitive therapy for suicide or problem solving? Great. I think just generally speaking, problem solving is sort of an area that has a lot of different potential options, and I think safety planning is one way of targeting problem solving, and it's sort of more of a very brief and focused way, and Sarah will be talking more about that and sort of the elements that sort of feed into that. But I think that is a particular intervention that has been looked at in different populations that are at risk for suicide. We are actually doing a trial too, where we're focusing on aspects of that cognitive therapy as well as problem solving for individuals with moderate to severe TBI. And TBI is a risk factor for suicide and in veterans as well, and looking at ways that we can sort of address that in pretty high-risk populations. Given that these are really, these are evidence-based psychotherapies and they are kind of more time-intensive, we really kind of need to be thinking about, when we have a patient and we do a risk assessment and we conceptualize that they're at, high acute risk or intermediate acute risk, what are some things that we could be doing right then and there to help increase their safety? And safety planning is something that really gives us that tool and gives us the ability to do that in collaboration with the patient. And how many people here use safety planning often with their patients? Great, okay, it's wonderful. I think there's ways to enhance safety planning, or what we call kind of supercharge safety planning, and we're going to be going over that with you step by step. There's a lot of wonderful applications, mobile applications and clinical tools that we can integrate to make safety planning sort of even more interactive and sort of more useful to patients. And I'll have, Sarah will be coming up to talk about that now. Any questions about the evidence-based psychotherapies specifically? Questions regarding like implementation in the VA or training? I know each facility differs in terms of sort of opportunities for training in these different areas, but I think generally speaking, there's a really smaller percentage of clinicians that are trained to deliver these therapies. And while they're really important, I think, again, just wanting to stress that you don't have to be doing these therapies or know these therapies to sort of like help manage suicide risk in your patients. So, transition to safety planning.
Question?
Yes.
I'm having a hard time formulating it exactly, but I'm kind of thinking about the fact that we're talking about evidence-based therapies, but they really evaluate risk that bears out over time. Are you recommending these are interventions for acute risk, but we're really dealing with that chronic risk?
Well, these three interventions are basically they prevent reattempt. So the time period. Usually the study is 6 months to a year time period. So yeah, and it is for a very high risk population because these individuals have already engaged in suicidal behavior. But what about all the people who haven't engaged in suicidal behavior and you identify them as being at high risk? What do we have in terms of interventions for those? It might not be that everybody needs this particular type of intervention or this intensive intervention. But something where we can enhance, something like safety planning where we can actually, it's brief, it's really targeted on suicide behaviors, and it really hits at some of these active ingredients like problem solving, might be some alternatives to be thinking about.
There's one exception to that. It's the Window to Hope intervention, which was developed by Graham Simpson in Australia for folks with moderate to severe TBI. We are closing in on that trial. It is a cognitive behavioral intervention with some problem-solving therapy aspects. And who we're recruiting in that study is not folks necessarily with a previous history, but folks who are very hopeless. And the idea is that we know that hopelessness is a predictor of suicidal behavior, particularly people with TBI. And so trying to target hopelessness to prevent future suicidal behavior. Similarly, we do, and right now we're doing an interesting treatment development grant. We just got a treatment development grant a while ago, where we're combining problem-solving therapy with safety planning. And actually, I heard that Barbara Stanley at Columbia is doing a DBT safety planning intervention. So again, combining these evidence-based treatments with safety planning and using the skills that you learn in the therapy, problem-solving therapy, DBT, to enhance the safety plan and to engage people in using their safety plan. So in the problem-solving therapy plus safety planning intervention we're developing, it's again for moderate to severe TBI. Barbara Stanley's work it's Barbara Stanley's, I think it's Marianne Williamson who's actually the PI on it. Theirs is for more with people with borderline personality disorder, pairing the two. But the idea is that we may need to do things to engage people, both in treatment and in safety planning activities.
And this idea that like this is sort of transdiagnostic too, that we need to be looking at this across disorders, across people, and not just actually psychiatric disorders, but other medical conditions that increase people's risk for suicide. I mean, just I feel like the problem solving is, I think, really big in very different aspects. Another tool moving forward, I don't know if people have heard about that at all. If you know, if you've ever been to the website, tried it at all. Moving forward? Yeah. Okay, so Sam, it was really, I mean, more for about reintegration, some like more stress management and problem solving around reintegration following deployment. But we've been looking at it sort of more in like a behavioral health settings and how it can be used to teach people about problem solving and how the impact it has on really functioning and coping. But it has a lot of really nice modules, and actually veterans, patients, you guys, anyone can go and try some of the modules, and it teaches some basic sort of coping skills. But I think, again, targeting it from like a lot of different angles. There's nothing specific to suicide, it's just more general problem solving.
Sorry, I just want to make sure people know what it is. It's a website that's free, and it was developed by the VA and DoD. Yes, I think that's true. You can access it anywhere, any computer, VA or non-VA computer. Have people heard of this? It's called Moving Forward. Do people have the thing with the VA resources on it? I think right there. Isn't Moving Forward on there? I think Moving Forward's on there. Can I just see? Okay, great. Oh, good. Okay, so I don't see it, but I've been told that it's on here. Oh, right here. So right here, Moving Forward, it's a free online educational and life coaching program that helps veterans to better handle life's challenges. It's OEF focused. It's really, really good. It looks super fancy. It looks like super fancy people developed it. It's really nice. So I've used this with veterans in my office. We do it together in my office, then they can do it at home. There's videos, there's modules, there's all kinds of stuff on it. So just another resource, something that you can use that's available to you as a VA provider.
They're like games that you can play to teach you the concepts, which is really neat. And actually does a really nice job of teaching you how stress impacts your decision making and problem solving. So.